It is 1 o'clock on Wednesday, November 28th. We'd like to welcome everybody here. And you are at, in case you don't know, you're at the Major B Citizens Oversight Committee meeting. We have a quorum, but I'd like for our committee clerk to call roll, please.
Janine Miller. Here. Jan McGorty. Carmel Angelo.
Here.
Ace Barish.
Here.
Ross Liberty. Lloyd Weir.
Here.
Mark Myrtle.
Here.
Jed Diamond.
Here.
Shannon Riley. Thomas Allman.
Here.
Donna Muschetti.
That a girl. Here. I know, it's all good. You got it.
Okay, I know that we have some corrections to the minute from committee member Muschetti. Has anybody had a chance to review the minutes? And Dora, if you could make a note that Jan McGorty is present, please.
Okay.
Has anybody had a chance to review the minutes and would like to make a motion to correct?
I move that we accept the minutes as corrected.
Donna has gone through with a couple corrections. Did everybody get the corrected draft?
Yep.
Okay, it was listed. So we have
Second.
a motion and a second to accept the corrected minutes. Any discussion? All in favor?
Aye.
Any opposed? Carried, none, so carried. Thank you very much. Communications received and filed, there were none, even for last minute. The clerk, no, okay, nothing. Public expression, we welcome public expression. We don't have a podium right there. The podium,
We did back there.
oh, it is back there, okay, I'm sorry. We do have a podium there. If you would like to discuss on any item that's not on the agenda, we welcome you to do so. Please state your name, and you have up to 3 minutes by all means.
My name's Darcy Nicholson. I'm on the board for Family Medicine Education for Mendocino County, which is supporting and is supportive of the medical residency program, which we just got finalized. There will be 6 physicians coming here in June to be welcomed to our community, and then for 3 years, 6 and 6, until we always have 18 physicians, new MDs that have just graduated from medical school. The reason I'm here is that I'm interested in being able to integrate health and well-being in all of the situations, whether it's for our physicians to be taking care of themselves, because women physicians have a 200% higher suicide rate than the normal population, and physicians in general have a 70% higher suicide rate. So our physicians need to be taken care of, and then I'm interested in our psychiatric situations where we address health and well-being with things like breathing exercises, meditation, mindfulness, yoga, qigong, acupuncture, all of the things that we can now say, yes, we have the science to prove that walking outside in the forest is a really good thing for mental health, or meditation is a really good thing for mental health. Thank you very much.
Well, thank you. And I welcome you to, we're going to talk about our agenda today. Our meeting dates for 2019 are back there. And if you want to stay in touch, I would welcome you to look at those. We always meet in this room. Thank you. Anybody else who would like to discuss anything of a non-agenda item?
I'm Cynthia Cole, and I would be very interested in knowing what's happening with the Training Institute.
Say it again, I didn't hear.
I'm interested in the Training Institute.
Gotcha, thanks.
Thank you. Is there anybody else who would like to address the committee? All right, seeing none, we are going to move on to the agenda item, and if you could mark the channel. And for everybody who heard Carmel Angelo say here, Carmel is on that phone there. She's she's in Southern California, but we've posted where she is, and she's able to join us for 1 hour. And if the minutes could show that Ross Liberty is present, I'd appreciate it also. He didn't count on government starting on time, is what happened. All right, so we are going to start with the items on the agenda. Item number 5A is report on Measure B tax funds, and this is from Member Weir.
Yeah, Lloyd Weir, Auditor Controller, we're gonna take a look at this document, which on the left-hand corner, upper left-hand corner says expense, revenues and expenses life to date. And in the right-hand upper corner says Fund 1224, Budget Unit 4052. Okay, this is a worksheet of our restricted funds that are coming to the county. We've been receiving them since late June. We'll start at the top portion, which is our revenues. As you can see, we've received 5 months worth of sales tax proceeds, totaling $3,117,756 to date. Any day now, we should be receiving our September payment. These are basically running about 2 months in arrears, so that's why you don't see a current October, November amounts. They're coming. Then we'll drop down to our expenses. These are the same expenses you saw on the last statement. We have had no new expenses added yet. They total $199,048. And also, if you drop to the bottom, you'll see the recap of the total revenue, the life-to-date expense, and also the fund is now starting to earn interest, is paid out quarterly in the county. So we've had about $3,400 worth of interest on the account. So our balance today is $2,922,108.
Okay, yes, Jan.
I have a question. Why are these negative figures?
Yeah, so in the county system, a revenue appears as a credit and an expense appears as a debit. So this allows for the formulas to calculate correctly.
But here the revenue is a negative.
That's correct. In the county's finance system, all revenues have a credit sign.
That's a credit, a negative.
Yeah, the negative in front of the number is a credit sign.
Oh, I would think it'd be a plus sign. Okay, thank you.
Sorry, I didn't know.
I had a question, Mike. In terms of the monthly revenue for credits, can you comment on why there's some discrepancy in months? Some fairly significant, August being quite a bit, 872,000 compared to some of the other months or less. Do you have a sense of what the variation is month to month?
You know, it is based on sales, and so, you know, that could be changing monthly. I do know that the state is going through a conversion on their taxes, and you know, this month in August could be a result of that. And every once in a while, you'll have entities reporting in the wrong, either inside the city limits and not outside the city limits. So we catch up with those at a later date. So they could fluctuate, but to date, this total seems to be running right about at what we projected it would for the year.
So you're assuming based on what you're actually seeing that this is pretty much what we can expect if we're looking into the future, trying to see what our revenue is likely to be.
This is our starting point.
Gotcha.
Costco opened in August.
What?
Costco opened in August.
Is that significant?
Part of it.
Okay. Okay, interesting. Yeah, that's kind of good. I like that.
Kind of interesting. Yeah. Any other committee members have questions about the presentation from Committee Member Weir? Is there any public comment regarding the Measure B funds?
I have one more thing to look at. It looks like this. It says at the top, 2018-19 Budget Unit 4052 Mental Health Act, Measure B recommended budget summary. Been informed by the CEO's office that there have been some invoices received for staff time, supplies, materials for the Measure B committee meetings and progress so far to date. Been reminded by the CEO that we really should bring a recommended budget forward for the board to approve. We are, already started this year. We were late in the process of being included in the county's budget preparation because we didn't get organized in time to participate in that. However, during the year, as the board is allowed to approve adjustments to the budgets, and in any department where, let's say, a major program comes up or a grant is approved mid-year, the board has the ability to adjust their budget ongoing, and we can take this opportunity to bring our budget forward as an adjustment for the board to consider. This is, I sat down and quickly put this together with some input from the CEO's office. We just need to get a starting point going so that we can have appropriations approved by the board and not have to bring each and every single minor invoice in front of them to be approved. If we could get an appropriation approved for some of the supplies and staff costing, then those invoices, as long as we stay under the threshold, we can approve and pay those here at the committee level and not have to bring each invoice to the board individually. So I have, and the CEO has attempted to estimate what we think we may or may not need between now and June 30th. So this would be a budget covering July 1, 2018 through June 30th, 2019. Fortunately, so far this year, we have not had any expenses in this year, so this will be kind of a fresh start from this point on. I'll start at the top, and you can see that I've projected 4 quarters of interest apportionments of $30,000. The 12-month of sales tax allocations at $7.5 million, which is in line with what we have received so far, and projecting that out. Looks like we're right on target for that number. So total revenues would total $7,530,000. I'm not anticipating any permanent employees in this budget unit at this time. And then if you drop down to services and supplies, we've attempted to put some estimates in for possible costs that the committee may incur. Not only ourselves, but maybe having things done by the committee. These are not etched in stone. In other words, if we do not incur these costs, there is no obligation. These numbers go away, and our fund balance remains $7,530,000. So only if costs would occur during the year between now and June 30th would we have to use these appropriations. I have $2,000 there for possible office expenses. Education and training was $2,000. Printing's $1,000. About $50,000 for contractors and consultants, and I'll talk about that in a minute. $500 for publications and legal notices. $2,000 for information technology equipment. $20,000. This is our special departmental expense. This is where we would be paying our reimbursable charges for staff time and other support staff working on the committee's behalf. And then any possible travel out of the county, for a total of $79,500. Again, this is just a starting point, and we can change this as we go, but at least it gives us something to kick off with and get us started paying bills. And as we make decisions, this committee makes decisions and we forward them to the board as recommended and they're approved, we can adjust our budget accordingly. So, and then the $1 million that I put in here is kind of basically a starting point for the development of a psychiatric facility, a behavioral health facility, or a regional behavioral health training facility, which are the 3 facilities that are mentioned in Measure B. As you know, in the county, all buildings will become county buildings. So we will have to have our facilities management be in charge of building or buying a facility. That way, it's all accounted for in the capital projects budget and can be reported on the balance sheet and at the end of the year properly with the proper depreciation. So what will happen is the purchase or the construction of a facility will happen in the capital improvements project and be managed by the buildings and grounds facility managers. And of course, we would end up having to pay for any other professionals we need to hire out of that fund also to maybe architect it, design it, plan it, and ultimately either buy it or construct it. So this is just, again, kind of a number that I feel could be possibly obtained by the end of June 30th. It may not. We may not ever, get that far, and that's fine. It may end up having to be more, in which case we would be able to come back to the board and ask for an increase. So right now, today, just estimating that at $1 million would bring our total net appropriations to $1,079,500. And if those would create a total fund balance available at the end of the year of $6,450,500 that would then carry forward to help fund for next year. So I just wanted to kind of get this out in front of us. It would be nice if we could get something approved by the board so that we could start paying our bills out of this budget unit and showing how we're doing. So I'm just wondering if this is possible that we could vote on this and have it brought forward to the board so that we can get a budget unit created.
So the Lee Kemper Consulting, would that have come, is that representative of the professional services line item there?
Yeah, so I'm sorry, I was going to go back to that. So in talking with facilities and actually with the CEO's office and others, one of the issues is going to be who's going to be in charge. In other words, when we're working with planning and building, when we're working with facilities, when we're working with an architecture or a real estate or whatever, really we don't want that person having to come to 11 people and listen to 11 different answers. I really think we need a voice, we need a presence, and that being a person that would be our eyes, our voice, and our ears, that would report to us and would in turn report for us, and be the one that these people will have to contact and deal with, rather than everybody coming to the committee and getting 11 different possible responses. So my thought is to possibly hire some type of an executive director. It doesn't have to be an executive director, you can call it whatever you want, but that person reports to the committee and ultimately the board, but helps us streamline this process we're about to enter into, where everything can go to that one person and that one person can come to us, we can resolve the issues, and then that one person can carry off our messages. So I just thought that would be a lot better than, it just seems like we're constantly floating around here with 11 different responses, and I just thought that might be one way the outside world could deal with this committee better. So just putting that out there also.
Okay, well, this was brought to us today, right? And it's not on the agenda, so we're not going to vote on it today. It's going to be we'll put it on the agenda for next month, and it'll give us an opportunity to talk about it. Is there anybody who would like to comment on this? Jed?
Yeah, I just had questions so I understand what you're proposing under this idea of an executive director. Would this be somebody? I presume this would go into effect as we're looking at facilities. Looking at creating facilities, not in terms of budget for some of these other day-to-day expenses of that kind of thing. And is the thinking that this would be a person connected to a particular facility that we might be recommending, or somebody that would be looking at facilities generally and would be looking at all the facilities we may be in process of recommending.
This would be our go-to person for the committee.
Okay.
This person would be our eyes and ears, our voice, and, you know, any information out there would flow through him to our board, or could come here, but,
Or her. Him or her could be.
yeah, him or her, I'm sorry.
Yeah.
You can just imagine if we didn't have the one person, what a hectic time it would be trying to get everything through. But that's just my thought. If there's another way, you know, if you want to contract this out and can, you know, hire a firm to do this kind of thing, you know, I'm not sure if that's, you know, if that's the answer, but I just thought, you know, having one person to represent us out there would be the best.
Okay, I think I understand. They're not necessarily connected to a particular facility that's being proposed. They're the go-to person that would be looking at anything that would be.
Yeah, I can
coming
imagine
through this committee.
that, let's say planning a building wants permits, you know, they're not gonna, you know, have to deal with 11 of us, they'll deal with that one person, that one person will come to us,
Gotcha. Okay.
that kind of thing.
I gotcha. That-
Jan?
Yes, I just wanted to note that the Behavioral Health Advisory Board has a similar recommendation that a dedicated project manager be hired to oversee the implementation of the recommended actions and manage the contracts that might occur.
Good, so it'll be on the agenda for next month, and if you could bring whatever information from the advisory board you can, you know, you represent them, I think that's a great way to go. Anybody else have a comment? Mark?
Yeah, you mentioned that any facility that we contract with or fund would be owned by the county. Is that a requirement?
It's county money, it has to be a county building.
Okay, so we couldn't lease,
Well,
we couldn't lease a building.
I'm sure we do lease buildings under the county's name.
Right.
Yeah,
Yes.
any kind of a contractual agreement would have to go through facilities and the capital projects budget, so.
Okay, because, you know, that makes a big difference about if you're purchasing the building versus
Sure.
a long-term lease of the building.
It does.
And also this $1 million operations transfer out budget, is that really for us to budget? Really, we're just recommending proposals to the board that's gonna be making those recommendations for
Exactly.
transfer now. So that really isn't relevant to us.
Well, it's relevant in that in order to spend it, we have to appropriate it. It has to be approved by the board. So I'm asking that we get a recommended budget approved. Now, when we incur contracts and consultants, professional services, all of those have to go to the board for approval before we can implement them. So the board will be approving any larger contract type agreements we may have ahead of time before we ever have to pay a bill on them. So this is just to set up the budget for it. It's not, it can be changed, it can be reduced, it can be taken out, but it's there in case going forward before June 30th, we have a contract that we want to get approved by the board and we have the money to start paying on it. So,
So basically, we're appropriating $1 million for budgets that will be approved to.
for possible facilities, purchases,
Whatever.
whatever.
Okay.
Any other questions? All right, from the public, is there any public comments on this item? Mr. John McCallum, not
John
supervisor.
McCowan, I am a member of the Board of Supervisors. You do have a legal opinion as part of your materials, and it's not absolutely as explicitly clear as it could be, but I'll state the obvious because terms keep getting used like we're going to appropriate money. The Measure B committee is strictly advisory. You don't appropriate a nickel. So I think the real action that is being considered on next month's agenda would be recommending a budget to the Board of Supervisors to consider adopting. And so, you know, I just think everyone needs to be continuously clear. The Measure B committee isn't spending money, it's recommending. I think the recommendations will carry great weight, but we just need to be really clear on what the process is. Thank you.
Well taken, thank you. Any other public comment? Ross? Yes.
You have $20,000 in here for special department expenses, and so I'm guessing that's for Dora, right?
Yeah, so, yeah, it could be Dora or any other requests we make to other departments for information or work that needs to be done that can be billed.
Just a couple of commentaries. Did you get an estimate on that at all?
I did, I took a look at the invoices that have been submitted so far and basically tried to project them out.
Oh, I see, okay, I haven't seen it. So we've been getting invoiced for.
We just now got them this last month.
Got it, that makes sense. And such a deal, by the way. And then, the other question, which you probably answered is so we can go out if we ask for some, Kit Elliott's opinion on something, that staff time that she spends on that's billable to the Board of Supervisors for the
It has
benefit
to
of
be
this
approved by the
committee.
board, yeah.
Just to make sure we're good on that. Question, thank you.
All right, it'll be on the agenda next month. All right, having no public comment, I'm going to change the agenda item because Carmel's on the phone and she's only with us until 2. And we're going to jump to D as in David, ad hoc group for Howard Hospital Partnership, support committee with discussion and possible action, Dr. Barish, Mark Myrtle, and Janine Miller.
So, I wonder if it's okay with Mark and Janine, if we could hear a presentation from Adventist Health, representatives from Adventist Health as to what some of our thinking is toward the locked facility. I mean,
I have no issue with putting them in front of us, giving their presentation since it was collaborative. Basically, my presentation is just what we talked about.
yeah, maybe you should go first.
Basically, there was a committee created, Dr. Trotter, Dan, I'm sorry I don't have your last name, Camille Schrader, from RCS, Ace Parrish, Jason Wells, and Janine Miller. We had 2 conference calls, one on 10/4 and one on 10/18. It was, Janine didn't attend the first call, but the second call she did. The total time was 2.5 hours on the phone. We discussed different options on how the local hospitals can help us, supporting us in the Measure B efforts. The options discussed were adding on to Howard Memorial Hospital in Willits, converting the ICU at Adventist Health into a medical psychiatric facility. I think there's a difference there. If there's a difference, qualify it for me, please.
In Ukiah.
Yeah, in Ukiah. And that would work to help supplement the proposed CRT and CSU at Orchard Avenue. Another option was a greenfield, develop a CRT CSU PUF unit on a bare piece of land. And finally, develop the old Howard Hospital into a residential treatment, psychiatric health facility, basically the plan that was proposed to us earlier. And Janine, you know a little more about that building than I do. So those are the items that were put on the table. On our 10/18 meeting, Jason Wells, an associate, went and did some research on what it would take to convert the local ICU in Ukiah to a medical psychiatric facility. And they put some rough budgets together of like $7.7 million for a 6-bed facility. And those were very rough estimates based on the timeline that we're put forth. The timeline to get this facility operational was budgeted at 2 to 3 years based on appropriations of money and lots of other things. You know, that's my take on the conversation. There was 2.5 hours of conversation, so I summarize it a little more. Janine and Ace, if you want to add to that or what I've missed, feel free.
I think I would just add that we did talk a little bit, at least Mark and I know Ace wasn't able to join us as we met separately with just the three of us, to talk about sort of next steps and really looking at, we have a lot of questions still on what is the exact type of facility. There's different funding depending on the type of facilities. What does that look like? What would it look like to do an RFP? There was a lot of conversation about a CSU, a crisis stabilization unit, being a locked facility and a PUF. What's the difference between the psychiatric health facility versus a psychiatric hospital, the number of beds. So I think we left with still a lot of questions on, we kind of got from Adventist what they thought their price would be approximately if they opened it in an ICU. We didn't get to really get what it would be if Howard built something, but we knew it would be a longer time frame. I think they were saying 5 to 6 years. Was what we were told, but I think we still looked at wanting to go back and look at what would be the proposed population, right? What are we serving? Who are we serving? And when we look at it, because we know the way that different facilities operate, the cost to place someone on a per day rate is different based on the facility. And so we kind of left with a lot of those questions still to look at.
So just clarification, there were, my understanding is 3 different possibilities looked at. One is a psychiatric hospital, which is a locked facility that's associated with an acute hospital. And in that particular circumstance, it was the vacated ICU that moved into a new building at the Ukiah facility, Ukiah Valley Medical Center. The other possibility is at the old Howard with the PUF unit and that's the locked facility, and then other services, because it's much bigger than we need for a PUF, and that would be 12 beds. And then the third is the crisis stabilization, crisis residential treatment, contiguous with the regular services, revenue quality management corporation, is that right? RQMC, and so that's a vacant lot now, but that would be a facility associated with crisis stabilization, crisis residential. Some of my questions are how this would be apportioned. I mean, for example, if we had a 6-bed psychiatric hospital, I think that the intent here is that it's run by Adventist Health, but I'll leave that to Jason, and that it's up to the Measure B committee to do the remodeling that's necessary. The one advantage is it's already OSHPD approved, and that is an OSHPD facility. It's a psych hospital. It's in an acute hospital already, and it would save money in terms of having to go about a lot of preliminaries. But I'll leave it to our representatives of Adventist Health to be more specific. Jason?
And I think we want to present with Camille and with Dan, who are here, but I can share, we appreciate the collaboration. It was two great meetings, and to have the county and Adventist Health and to have community leaders partner in this strategy. First and foremost, Adventist Health is committed to being a part of the solution, and I appreciate the chance to be involved. We looked at how could we meet the greatest need as quick as we could, and the Howard option, what we went through at Ukiah recently, building the new ED and the new ICU was a 5 to 6 year plan. With OSHPD, it's just difficult to kind of move quickly, and so we knew that to do with a critical access hospital, as we have at Howard, we're allowed 10 psych beds. And as we kind of looked at it, it's something that's doable. It's a 5 to 6 year roadmap. And with the new ED that's opened up and the new ICU, there's an area where there's 6 ICU beds. Those of you who've seen the ICU at Ukiah Valley, that area is now open. And so Ryan Quattlebaum is the CFO at Ukiah Valley, and with Gwen's retirement coming soon, he's the senior executive there. And so he's been very helpful in this process and has jumped in to figure out what could we do with those 6 beds. If we were thinking of greatest opportunity for jobs and one need, an orthopedic joint center would make a lot of sense there. Hospitals are tripping over themselves to open up joint centers, and we have an amazing one up in Willits. That brings revenue, that brings jobs. Hospitals sadly aren't tripping over themselves to open up psych facilities. And as many of you have pointed out, Sonoma and around, they're closing them, and that's sad. And that's why we have this need, and that's why we're in this situation today. So we would like to be a part of that solution. Ryan has put a strategy together that originally we thought was about a $7.5 million. We felt we had to have a kitchen, and so he's done some great work with the state, and there is a waiver on that. And so we don't have to open up, and with your help, you knew that, you knew that from the beginning, but we had some bad information. So without that kitchen, it does come back down into about a $4 million number. But we tried, at the request of the committee, to get to an 8-bed. And it goes back up because we've got to push into a whole other area, and there's support walls and all types of things. So to keep it at that 6-bed unit, which would just be a bridge to a longer solution, whether that's Old Howard, whether that's building a greenfield, I think that 6-bed buys us some time. It's not the end game, clearly, from that. But what I took from the end of all of our meetings together is the number one need really is crisis stabilization. And Camille and Dan are here to speak about that, and we felt that would be the greatest good that you all could take to the board as an opportunity, and we fully support that as being really our first step. In the meantime, since we met, before I turn it over, I want to recognize the Frank R. Howard Foundation, because as we've been trying to figure out what to do, they really stepped into the void and have put up $135,000 to seed a project with Redwood Community Services where we will take a facility in Mendocino County, an existing house, and be able to kind of be the bridge strategy as we go to the crisis stabilization unit. And so Arnie, thank you. Their board met last week and committed that $135,000 to that project, which is a significant investment in the mental health, which helps the patients that are sitting currently in our EDs, the 5150 patients that we need to find a home, that an ED is not the right place for them to be. And we can't place them elsewhere. This house will be a transitional strategy, and thank you, Arnie and Margie and the team for doing that. But Ryan, do you want to add anything to your research?
Yes.
Yes.
I just want to, for members of the public,
Yes.
Explain your acronyms.
I'm so sorry. Thank you, Don.
Thank you.
And the acronym, the 5150?
No, the ED.
Oh, emergency department. Thank you. Oh, gotcha. Not erectile dysfunction.
Yeah.
Okay,
That's what I was curious
I got
about.
you where you're going with that. Ryan, take it away. Yeah, another question.
Oshkosh, you wanted to know.
OSHPD, oh my goodness. Office for the Public, help me with that one.
Office for the Statewide Health and Planning Division.
Thank you, Ryan. Impressive. Yeah. It's an important department, but if we do anything in the walls of our hospital, even in installing one of these devices so the door can be propped open, you hit a button and it props open so someone can come in on crutches or a wheelchair, it can take over a year to get permission to have a door opener installed. It's difficult. Ryan.
So I can talk about some more specifics about the ICU space and what we were proposing and what we had looked at and evaluated, and appreciate Janine's help in kind of understanding what that would look like. So right now we're talking about.
I'm sorry, can speakers introduce yourself before
Yes,
you start talking?
absolutely. My name's Ryan Quattlebaum. I'm the CFO at Adventist Health Ukiah Valley here in Ukiah. And what we were looking at as far as the ICU and the backfill is, as Jason said, we have the new ICU that opened here in October, which we're very excited about. But the old ICU space is now sitting vacant. And unfortunately, it's only 4,500 square feet. So that would require some reconfiguring and knocking down of walls, which would be that cost that Jason was referring to. However, with the help of Janine and looking at the kitchen and what we would really need, we'd be able to make 6 patient rooms that would include ADA compliance with bathrooms and sinks and all of that would be required. Also knocking down walls and creating a common area. So that would also be a separate locked portion of the hospital and what's already existing. So we feel like we could have the space that's there while keeping the patients here in our community. So we're not having to send them out. I think from talking with Dr. Marvin Trotter, who's our CMO, he said the county spends somewhere around 1.6 million sending patients out of the county to get care in some of these units. So we feel we could help bridge that gap and provide that need here and keep patients local and really care for them in the way that we know how and keeping them local. So that's really some of the specifics that we looked at and that we've uncovered.
What about the staffing that would be required for that? Would you be providing that also?
Yeah, so being within the walls of the hospital, we'd be responsible for the professional staffing. That would include nurses, the physician coverage, etc. Yeah, exactly.
Another question. What would be the time period you'd be looking at that somebody could stay in a facility like you described?
And when you talk about the time period, do you think how long would they be there? Well, it would be a general acute stay that they could be able to receive treatment and services. And the benefit of being in a unit that's just adjacent to the med-surg unit, the ICU unit, is you have the complement of services that are there. So they could be there, anywhere from 1 day to many days if needed. So that would really be the benefit of having them be there.
Is there a limit? Many days?
No limit.
No limit?
There wouldn't be a limit. I mean, and I think Janine may have more.
So it depends on if the client was voluntary or not. So if you're on a 5150 hold, it's 72 hours. It can be extended to a 5250, which adds an additional 14 days. And then if the County Board of Supervisors was to approve in our community that we would allow for 5270s, which is an extension to allow for like a 30-day stay, and it's an additional stay, which allows for when you're trying to get an LPS conservatorship or someone who needs more longer-term stay. But the County Board of Supervisors has to say that we will honor 5270. It's not specific. So some counties do allow 5270, some counties don't. But if we just had 5150, 5250s, you're looking at a 3-day and then a 14-day stay. Or if someone decides to stay voluntarily, as long as the hospital decides they meet criteria to keep them.
Yeah.
Okay, thanks.
We wouldn't kick anyone out.
Right.
Even if
And if Ukiah Valley, Adventist Health, Ukiah Valley was able to do this project, you've given us an estimate of the time, or the money, is there an estimate of the time?
In terms of the time to actually open and be ready to go, that's where the OSHPOD requirements would be a little sticky because it may take anywhere from 12 to 18 months potentially. We haven't got exact bids from the architect and the builders for what that timeline would look like, but really depends on OSHPOD because we come to them and then the clock starts running and it could take them anywhere from 60 days to just approve the architecture and then move forward. So there could be some potential delays that I don't want to be, I want to be transparent, and some of those could take time.
We felt that mid-2020, somewhere inside of the year of 2020 is doable.
Us?
So I'm a little confused. What I got from what Lloyd was saying is if the county spends money on a building, it's going to be their building. They're going to have ownership. And I didn't know that that was the case. But what you were talking, it sounds like you're proposing, is that the county spend the $7.5 million to upgrade, to convert the ICU or format, whatever it is.
Yeah.
This bunch of money.
Yeah, so obviously.
And I wasn't planning to write a personal check for that.
Exactly. No, and that's news to us as well. So if it's not appropriate, then clearly we're not going to ask for that. But
So, if we decide to secure a facility on the county's behalf, that has to be a county building and be in our possession. If we're going to lease it or if we're going to, rent, then those are different options we have out there. But I was just speaking to the fact that Measure B, as a measure, says we will develop facilities. So I'm just trying to get it out there that if the county is going to purchase or build, that needs to be a county building and in our county system.
So that being the case, if they're proposing that Measure B money be used to renovate, or whatever the right word is, their facility to accept 5150s or whatever, right, then that has to be county property, or it's, because it's not a rent, it's not a lease?
No, it wouldn't be county.
Carmel, you have something to add?
Yeah, thank you. In a case like this where the hospital, their renovation is actually their renovation, we would contract with the hospital to, we could either purchase the beds, bed days, or just contract with them to provide the service. So that's what I could see that would be I think, most appropriate if we were going to look at a model working with the hospital, whether it was UVMC or Howard.
And I think we.
New Howard.
You bet. I think we work out a very long-term lease, so your investment is gonna pay dividends for years and years to come, where these are your beds. It's not that we tried this for 2 years, we lost tons of money, we need to open up our joint center. That would not happen. And we would enter into a very long-term lease that you were comfortable with, that those were your beds. And they are county beds to be used for,
Yeah, so we have to really look at a cost benefit analysis, and I think that, one of the great values of the Measure B committee is having all the talent at the table and to really look at the various models. I really appreciate looking at this one and the work that's been done by this ad hoc and certainly by Howard Hospital and UVMC. This is certainly something that is a model that could work, and other counties do contract with hospitals in their counties to provide services like this. I am going to be off the phone in about 10 minutes, so I just wanted you to know. But what we would do is, you own the building, we would contract with you for the service.
Great, thank you, Carmel. Shannon?
So I understand contracting for the services, but we're talking about construction of the facility, and if we're talking about a $4 million construction project, is there no way for the Measure B funding to participate in the actual development of the facility?
Those are all good questions.
And would it trigger prevailing wage?
So we will get a legal opinion on this. It'll be on the agenda for next month, and we'll have this. We'll have a presentation on this. Find out.
And I assume the $4 million does not include prevailing wage, or does it?
If it's our money,
It would have to be if it's Measure
if it's
B
a
money.
lease. Yeah. Or if it's
Their improvements first.
That's what lawyers.
Yeah.
We can get lawyers to answer this question.
right.
Pay lawyers prevailing wage to answer the prevailing wage question.
So part of our 15 minutes, which, sorry for going over, with Camille and Dan sharing really the top priority of the residential, is that something that we would have time to do?
Continue on, sure.
Thank you.
Are you wanting us to do
Yes.
this out of agenda?
Yes.
So we're on the last on the agenda. But
Understood.
it has been launched.
Okay, we are going to Measure B, or letter B, I'm sorry, and Chase is asking you're part of that, so.
Okay.
you can do your presentation.
So just to remind the committee and the public that we were asked at the last meeting, we presented the physical plant proposal for the crisis center that is currently bare land purchased with SB 82 grant funding. By purchasing that land with SB 82 grant funding, we have committed to a crisis residential at the very least project on Orchard at this point. That was directed by the Board of Supervisors and the Behavioral Health Board 5 years ago. So it does have a timeline. I don't know what that timeline is. Our mental health director might be able to tell us. To answer, in that case, we actually did get a legal opinion and were able to have Redwood Community Services, which is a local nonprofit, purchase that land with the agreement of a lifetime lease for the purpose of crisis residential and crisis center services. So there are many examples of how nonprofit communities in partnership with county mental health or county social service or county anything, frankly, government, arrange to have property and services and supports built. The most recent examples are multiple SB 82 projects across the state where they ran into issues of prevailing wage and land purchases and the difficulty of getting land projects built. So I'm glad to hear that next month you'll have somebody come to speak to that. So if it was the will of this commission and ultimately the will of the board to do that, you can secure that the use of that building is done for the life of the use, and that based on contract agreements, you may use public dollars to support local nonprofit building and supported buildings, just in theory. So this is one of those examples. I'm bringing this today just because it has been a process. We've been working with the County Department of Mental Health and Redwood Community Services as your crisis provider for about 3 years on this project. It's for information only. You could certainly consider buying back, somehow transferring the title of that land to the county and making it a county-owned project. But for the purposes of today's project, we talked about the work that we were instructed by this committee to do, which was meet with Adventist and with RCS and talk about what that kind of a relationship would look. The project I'm going to talk about can be a standalone. It's not linked to whatever model you choose around the inpatient hospital. And the inpatient hospital does have so many sticky widgets that I imagine you have quite a bit more research to do. So I will be passing out, let me find my master copy that I wrote notes on. Here we go. This is just a general overview of the operations. So we did talk about physical building, and the commissioners were wonderful, actually. Mr. Myrtle is pretty amazing on the physical building end. We had some initial planning done. That can be, we actually have a new architect. We've already talked about the difficulty with the old architect. And those things can be revisited. We're looking at trying to simplify a few things, make it possible to, but the model was 10-bed crisis residential, which is the SB 82 grant that we received for $500,000, though it would have cost $1.3 million, I think is what our original proposal was. They funded $500,000 of it. At that point, we knew we were going to need to leverage not just funding and financing to build the building, but also staffing once that building was built. In the meantime, Redwood took over adult crisis support services and learned very, very fast the growing need for an alternative to inpatient psychiatric care. The numbers just went exponentially up, as you know, the Kemp report shows, exponentially up since we began doing crisis services in 15-16. So research has proven that a third of them can be diverted from inpatient psychiatric if you have a front-end continuum of care, which is crisis residential and crisis stabilization, which is a locked facility. For the purpose of both supporting staff and also supporting ease of use between programs, we were imagining the program to be one building, right? So the other hope was, and I did do some initial research about a year ago with the state around the idea of having a waiver where you only had to have the CSU open when it was in use. We talked about the pros of that being, if you did, I was hoping it was going to be an 8-bed, frankly, to all due respect. I really wanted it to be 8 or 10. But if the inpatient psychiatric facility were at least 8 to 10 beds and you had 4-bed crisis stabilization plus the 10-bed crisis residential, we would move our crisis access right now that's on Gobi into that site as well, sharing staff, sharing psychiatry, sharing overhead, sharing, and also having we imagined this picture of a coordinator that says, and this could happen even if it were Old Howard as a inpatient psychiatric or the 10-bed New Howard add-on. It's not dependent on this particular model. Having said that, the idea of having sort of somebody who coordinates, and if the CSU is going to be the biggest cost driver. So the CSU is what you want to control how long your clients stay in that. Because right now, you can only bill for it up to 23 hours. 24th hour, they need to be gone. We're hoping that legislation's changing to extend that to 72, which would make this a whole different conversation. But currently, you'd want to have somebody calling the hospital, working directly with somebody saying, is there somebody ready to step down into the crisis residential, have a bed in crisis residential, somebody steps out of inpatient, they go to crisis residential, and you have that client in the CSU moved to the inpatient psychiatric facility. It would take that level of really working and providing so that we don't run up the costs on the CSU. So those are sort of with the idea of a waiver that lets us close the doors when we don't have clients in it. What you have here are the combined costs of what that crisis residential CSU would look like. Let me see if I had my cover budget. Yes. Here we go. So some of this is made up of current dollars we're already spending. So in crisis response, it's somewhere between $1.5 and $2 million countywide, so probably 1.4 of it inland and Willits, that would just transfer over to the new building. It's crisis access, it's outpatient, it's assessment, it's crisis response is what we're calling it for the purpose of this. The new services would be the crisis residential treatment, which we assume will allow some savings in crisis inpatient psychiatric hospital, and crisis stabilization, which is the one piece that that variable needs to be managed very, very carefully, but is a viable, definitely less cost per day than inpatient, but the limits based on hours make it cost prohibitive unless we use it wisely. So for the purpose of this conversation, we used Kemper's recommendations in his budget and tried to merge it with the model that we've been working on for the last 3 years around that Orchard Land project, and that's what you have here. So you have the operational cost. This is not facility cost. You asked us today to present the operational cost for such a facility, so that's what we've done. Last month we presented the approximate 4.7 to build out all 3 of these programs into one building. So the new CRT realignment match, so the county pays 100% of the costs, and they send it to the state, and the state sends it to the feds, and the feds send us back a minimum of 50% reimbursement, okay? So when you see this, and this is for the public as well as for you, so when you see 50% match, that's in the end, the county share of cost if you're leveraging Medi-Cal dollars, okay? So for the new CRT, the new dollars would be 542. The new CSU, at the end of the day, right, so you pay, you submit up, you have a certified claim, it comes back down to you, it's a minimum of 50. Right now it's 60%, I think, federal financial participation, so the feds give us back 60% on the dollar. The new CSU is $561,689. The existence crisis response is $850, so that would just move into this new building. There's no new cost there, and actually that might be saved by being able to move people in the crisis residential sooner. So the total county costs of realignment 50% match is 1.954. Clearly it's a double, the full-time cost is double that, but that's how much at the end of the day your county Measure B dollars or other dollars would be used. Almost 850 of that is current dollars being spent right now. If we do what every other county in the country has experienced by having a crisis residential and a crisis stabilization, we assume a minimum of a third reduction in the daily clients needing to go to a hospital, which is right now about 15. And so the county share of that is $213,998. That's a minimum. We want it to be really frugal in that number. That could go towards the county match. So these are the estimates and details we gave for you. As I stated, the second page you have are all of the requirements in order to run a crisis residential and a crisis stabilization unit. So you can see the sort of high cost characteristics. The good thing is that you can have a medical doctor be your medical director, not a chief psychiatrist, which would be very, very difficult. You need psychiatric services, but you don't need psychiatric services full-time. You need an MD full-time. So that's probably one of the primary things that make it less cost prohibitive. So it would not and does not in any way replace the very intense need for an inpatient psychiatric medical facility. I'm not sure, at least from what I understand about financing, that we're clear which is best, whether it's a psychiatric health facility, otherwise known as a PUF, or a med clinic attached to an acute hospital. On the finance side, I feel as if it's very important, if we're going to be wise and smart about our dollars, that we have the answers to what I call the 134 account. So that question is still out there, and I think would drive on the inpatient, and we absolutely need an inpatient, whether it's an 8-bed, a 10-bed, or a 16-bed. This doesn't change it. We would reduce the numbers needing to go in, and we could reduce how long they stay in, both of which will reduce psychiatric costs, offset by crisis stabilization, crisis residential costs. So I hope I haven't been too confusing.
I'm sorry. I'm sorry. Camille, if with what you presented last month, or last meeting, on the building itself, was there an estimate of if you were able to start building, how long that would take?
We believed that we could have it like summer 2020. 18 months from the point at which we said yes, we could move. Yeah, open in 18 months is what we're imagining. Partially, and that answers the other question of, can a private nonprofit take public dollars to support a facility, own that facility, and be in a lifetime agreement for the use of that facility? Yes, it's done all over the place, and it can absolutely be done. Whether it's Adventist Health, whether it's RCS, whether it's Timbuktu Chew nonprofit in Alaska. But the second piece of that is the benefit, and we did this just in the CDBG grant that we received from the county on the homeless shelter. The private nonprofit can use market rates, and that's why Shannon's question. And a public entity, if we hire in-house as a construction team, which we were kind of forced to because of the fires, it wasn't really market rate issue that forced us to hire our in-house construction team. It was because we couldn't get anybody to take a bid. But the end result was that we could use market rates instead of prevailing wages, which is, it's definitely a reduction in overall costs.
Russ?
Yeah, I want to make sure I was going
Please.
to say something else, but that last comment. So I was maybe laboring under the misconception that if we're spending public money, no matter who puts it to use, that ultimately it has to be prevailing wage.
We were under that understanding too. We went to the state on the CDBG, and I definitely agree, frankly, with our sheriff that having somebody come next month and answer these 20 questions would be very good related to this initiative for sure. But I know and have a current example of using public dollars to support the building of a winter shelter day resource center with in-house construction team, allowed, authorized, and written by the state of California to use market rates, and as long as the internal construction people are employees of RCS.
Let me just add to that, if we got a bid and we did have to do some procurement where we went out and got bids for certain elements, that was prevailing. Those bids were done on a prevailing wage rate. If you're using your employees as workers, and I know you look a little skeptical.
Yeah,
but that's
okay. Well, we're going to have
get further
We're
information.
going to have an expert. We've done it currently. I understand your concern. I think the expert's a great idea.
So my questions that I was planning to ask until you
Yes,
dropped on me. So my questions I was planning to ask are, my recollection, and I'm perfectly happy to be corrected on that, but if my recollection serves correctly, last time we talked, last time in the meeting, that you were not really stuck on owning the building.
No.
The county you would be fine if the county owned the building and the dirt and the whole thing.
Send the title back and give it to the county. And
You're good with that.
at this point, I'm presenting to you,
Wonderful.
frankly, work that we've done and lots of investment that we've spent over the last 5 years trying to answer the need that ultimately upfront, if we don't solve crisis residential, and in my personal opinion, crisis stabilization, we don't fix the inpatient psychiatric need, which exists and will exist, and we absolutely have to solve. So that's my only point. If the county wants to, we sign over title to the county for that front orchard property and the county does it. If the county wants us to sell the property and give the dollars back from the SB 82 grant, because that's what purchased it, we will do whatever this commission and ultimately our board of supervisors tell us to do.
Well, thank you for being so customer centric.
You're welcome.
And then my other question.
We will build it for you and give it back to you.
You know what? That's
I
just
don't really
awesome.
want to do that.
That's
but
awesome.
If
So-
we get something built that
Yeah.
helps our clients, that's good enough for us.
I appreciate that. And then the other question was, there were some, you and I had a discussion on, simplifying the building or whatever. I don't know if you had a chance to look into that and see if it
So
was.
Dan can speak to that. We did take your advice, we took all of the advice and tried to work on it.
Yeah, so
Thank
we
you.
actually are working on that, and I think we've made some progress. The kicker on this is prevailing wage. So if in fact the whole project has to, we may not be able to move the 4.7 down very much with even cost savings. But our plan is to come back, if the board's interested, with a revised floor plans and a kind of more detailed construction.
Yeah, and the building you guys had laid out was gorgeous, right? I mean, it's just an absolute beautiful building, and
But there's ways we can save.
You'd be a great neighbor, I'm sure. Mr. Seltzer would love that new look.
Well, we were partially thinking of the neighborhood.
Yeah, and that's a
Shannon.
great thing. And the other extreme though would be just a box, right? And that would be cheaper, but at least there's something in the middle. And
We did talk about bringing modulars out of the property and say, let's do it, but Shannon probably wouldn't be happy about that, so.
For Camille? Mark.
What is the annual contribution required from Measure B to fund the CSU CRT?
So the new dollar is what you would be thinking theoretically, and we don't know what happens with Medi-Cal realignment and the dollars that come in every year, right? So whatever allocation the county gets, and I would leave that to my county partners to decide. But theoretically, all things being equal right now, the new dollars would be my page is different than yours, so
The 500,000 is what we,
it's $1 million.
well,
The new match is $542,805 for the crisis residential treatment, and the $561 for the CSU, and that's the most because we believe that there'll be savings both on the crisis response side and on the savings from what we currently pay for inpatient hospitalization, right? So that $231.13 that's the most that we imagine at the 50% match. So it's $1.1 million.
1.1 million annually to support the income for the CRT and CSU.
And crisis response program.
What's the 500 above?
That
number.
this
CSU.
Oh, right, so these are,
This is county
yeah,
match.
so this is county match dollars, may not be
Especially
Measure
mental health,
B.
It's not Measure B.
The Measure B was the CSU 500,000.
Right. So I'm having a
This is
hard
from
time.
This is from Medi-Cal billing, so.
Yeah, that's where I'm having a hard time. Is the revenue $1.9 million that comes in?
The revenue is 4.9. 4.9.
And then so 500 of the 4.9 is
From Measure B.
Measure B money.
That's correct.
Right.
So what are the others? What's
So
the
we don't
other
know where the,
561 and 540?
that's new county share is what it would be. It would be new county share for operations for the Medi-Cal dollars to get to the
I don't
4.9.
understand that, I'm sorry.
So,
Can you?
So Lee Kemper had written in his report to dedicate $500 towards the offset of the CSU, right? So if
$500.
500,000 a year to the CSU, and then from that baseline, having, and I frankly think if we handle this other piece a little better, that could be reduced, but I won't speak to that. And then the new services and supports would be based on that coordinator making sure that those clients that are in there stay 23 hours, move into crisis inpatient, or go to crisis residential, both of which allow us to continue to bill Medi-Cal, but are not in the CSU for longer than 24 hours. For those 24 hours, times 4, times 365, it's the $561,000 in Medi-Cal county share of cost for whoever runs it.
maybe just add to that. So there will be special mental health services being provided in the CSU and the CRT. That's where the total revenue, those are billed dollars. But as Camille talked about earlier, there's a share of that that's federal, and then there's a share of it that's county match. And that's the second set of numbers, is the county match portion of those billed services. So the most of the operating dollars are coming from billed specialty mental health services.
You have a client, you serve that client, you do a quality documented claim.
And that's how it works right now with Medi-Cal service. And I know, Jeannie, if you want to kind of add on to that, but that's what funds all our mental health services. We provide a therapy service, we bill Medi-Cal, 50% of that dollar comes back as federal dollars, and the other 50 cents is county share. Is that?
Well, we're going to deal with Measure B issues today, and I appreciate the reimbursement from Medi-Cal and so forth, but it's outside the purview of Measure B.
Well, the only reason why it's described in the operations is you asked us to present our operations.
I understand.
and you
We keep
can't-
Bill, Greg, or
You can't provide
Down,
operations
down,
without
so-
Medi-Cal.
So,
any questions for Camille?
were you gonna mention the Sims Lane property also? Or is that?
No. It's not really party to this, it's more crisis respite support until we get to a Measure B solution. So I would,
That's what Jason was
Yeah.
referring to, the Howard Foundation, they're gonna.
it's not a CSU or a CRT,
It's a bridge, it's
respite,
a bridge facility just until we get.
just till we get this. It'll solve some of the problem, but not much.
Yeah.
So I see the 500,000 in year 2, 3, 4, 5 of Kemper's report. It's not, it is continued, so that's
Right.
25, according to the projected income, that's 25% of the total projected income past the 5-year
Right.
mark.
I think that several other things could reduce that amount,
And that was my
but we
question.
used, yes.
Were we anticipating that having that in our county would reduce the expenses for sending people out of county?
Right, this may free up actual county dollars to support that, releasing Measure B. What this is based on is his very detailed research of how CSUs work otherwise, accepting those assumptions without the fact that we're pretty good at moving and taking care of our clients in a way that allows us to
Was there any figuring in his report where those outside expenses would be reduced so that it wouldn't be?
He didn't look at the Medi-Cal
Look
side.
at that. He
So
didn't look at
that's,
the state.
right, so, and I appreciate what the sheriff's speaking of. We took it from a general macro, using that as the baseline assumption, and making sure that we didn't understate it. So I think that when you do some real detailed analysis, you look at it, that could be less.
Any more questions for Camille? Mark?
Again, the annual cost to Measure B is 1.1 million, 1.6 million,
So
500,000.
for the purpose of this presentation, it's the 500,000.
500,000, okay.
Any more questions for Camille?
Yeah. In terms of both the presentations, and I hear if there was a inpatient residential hospital, as you described, that would link into this, both of those would be in Ukiah, right?
Right.
So I'm wondering if, we haven't gotten to this yet, but if there was a decision to recommend the old Howard Hospital as a residential, is there any downside of having your facility in Ukiah if the residential was going to be in Willits, or?
There wouldn't be any downside fiscally to this. There would be, logistically, you'd need to have an ambulance move someone from the CSU to or actually we could take them, once they're on a hold, a crisis person could take them from our facility in Ukiah to the Willits issue. So on the linkage side, it doesn't matter. Whether it's a 10-bed at New Howard, I love an 8-bed at at Ukiah, keep kind of imagining somebody thinks of that, and or a 16-bed puff, that piece, there are issues with that piece that it seems prudent to look at in terms of deciding which of those models work. One of the advantages to a medical model assignment is that our population is aging, and so they tend to have complex medical needs as well. And you could have them in a hospital on a medical placement, not a psychiatric placement in terms of meeting two banks. But there is cost. Those costs are higher than a puff. And frankly, really the issue is just knowing what happens at the state level in terms of losing and or gaining dollars. So,
Okay.
no, there's no real, that person still needs to be very top on when is this CSU client running into the 24th hour. The relationship with whoever that operator is needs to be written in the contract that they must respond to, this one's ready to leave, let's move them to the crisis residential, have the crisis stabilization client get into the hospital sooner if they need it. That piece would happen no matter what. So no, it's not dependent.
Any more questions for Camille? Any public comment?
Jason wanted.
I was going to add to Jed's comment there. 742 patients in Ukiah's ED, 5150. So being close to the project would be very strategic. But we're shipping the inpatients, many of them out of county already.
Mm-hmm.
So Old Howard is closer to home.
Right.
Yeah.
All right.
In the Kemper report, he said that it was gonna be costing something for you to build the crisis residential was gonna be like 4.5 million, or excuse me, it's ballpark?
The whole crisis complex is
so
4.5.
Where does that money come from?
That would be Measure B building facilities. That was not what we were
Okay.
presenting today. We
Okay,
presented those at the last meeting.
thank you.
We're following
Thank you.
our directions.
Just checking on that one.
Okay, any more questions? We're moving on then. All right, thank you very much.
Thank you.
And Carl is no longer in the room. All right, so moving on to the next agenda item is, we're going backwards to item 5, B as in boy, the calendar for next year. I hope you've had a chance to look at it and see if there's any conflicts. Does not appear to be any conflicts with holidays or so forth. And if somebody likes it, we'd like to have a motion to accept our calendar so we can distribute it to the public.
I make a motion that we accept the calendar as described.
Second by Member McGordy. In discussion? Any public comment on the calendar? There is none. All in favor say aye.
Aye.
All opposed? Hearing none, so carried. Thank you very much unanimously. All right, so we are going to measure, or item C is in Charles, mobile outreach presentation by Member Miller.
All right, so I handed out a documentation. There's also some put on the table if you didn't get it regarding mobile outreach and prevention services. We currently have 3 mobile outreach and prevention service teams in our county. The first team started in December 2014. The team is a makeup of a sheriff service technician and a mental health rehab specialist. It's a joint project that is a joint project with Behavioral Health and Recovery Services and the Sheriff's Office.
I mean, we didn't get that.
Okay,
Are they all, are they going around right now?
Oh, they're over there.
passing.
There was a bunch on the back table. I did.
Did you grab 2 more?
2 extra copies here if anybody wants. Debbie.
You need one.
All right. Sure. We've taken an unintended break, but we're back. All right, I'm sorry.
You need one.
Continue on, thank you.
Okay.
I think we have.
All right, so we have 3 teams currently operating in the community. They are a joint program with the Sheriff's Office and Behavioral Health and Recovery Services. The team consists of a Sheriff Service Technician and a Mental Health Rehab Specialist. The individuals, the team is out within specific communities, serving that community. We started the project with one team really trying to serve 3 areas. And the one team ended up spending a lot of time in Covelo area and kind of North County and doing a lot of work up there and wasn't able to serve the other areas as much as we had hoped. And so we then decided we really needed it to expand to 2 teams, which is we expanded adding a South Coast kind of Anderson Valley team. So they were serving those 2 communities with our first team staying up really serving North County area. And then we quickly learned that we really needed a 3rd team because our second team was spending a lot of time in South Coast and we really needed to dedicate a team to our Anderson Valley and Hopland area. So we added that 3rd team. The team is mobile. They are out in the community working with community agencies, going to the homes of individuals. They take referrals from just about anybody, family members, community agencies, law enforcement, probation. The team is usually gets a referral that there's an individual that needs some mental health services. So the team will go to the individual's home, work with building rapport, because they're not always trusted right away when 2 people walk up and say they want to help you. So they've done some great work on building rapport, especially in the communities. I get a lot of positive feedback from the Covelo community about how much they love their MOPS team and couldn't imagine not having it now. And there's a lot of kudos about the teams just across the county. So So they're out there, they are supporting individuals, they're connecting them to local community resources. They will do some care management with those individuals. If they're not able to connect them with the community resource, they become the care manager. We do a lot of work of trying to get them connected. They make sure that they get connected for medication support services, psychiatric services. They will take them to their med appointments. They have taken individuals to court. They have transported individuals to rehab for substance use, rehab and detox services, and really work with the individual and the family members. So as I said, we have the 3 teams. We have the North County team, who really is North County, Covelo, Laytonville, Leggett, Piercy, Branscombe, and really serving that area. We have our South Coast team that really does sort of the Gualala Point Arena, Little River, Manchester, Mendocino, and then we have our Anderson Valley Hopland team serving really Boonville, Hopland, and Philo and Navarro. So what we were asked today was to come back and kind of present, what if we added 2 more teams? That there was a desire to increase mobile outreach because it's been very effective in working within the communities and decreasing the phone calls and dependency on law enforcement. I think that's really been noted from the sheriff's office, that the effect that it's had for them. And I also included on this report just a little bit of the numbers that we've served through this fiscal year. You can see the number of clients that they've served. In July, they served 48 clients. In August, it went to 59. September was 57, and October was 56. For all of the teams, yeah. And remember, that's the individual person. They touched 58 people, let's say, but they probably saw them way more than one time because they're actually working with them on a daily basis to make sure they get connected to services. So as a proposal, we sort of talked about if we added 2 more teams. I've got feedback from some of the communities that feel they would like to have a mobile outreach and prevention team within their community. And so we looked at if we added a team, what would that look like? One thing we talked about is a North Coast team, which would serve from Westport down to Lake Little River. And that would allow serving within Fort Bragg, because I know there was some feedback that Fort Bragg would like a mobile outreach and prevention service team within their community also. So we took that into consideration. How could we support sort of the North Coast, because we were really supporting South Coast already. And then we looked at an inland team, which would kind of be looking at Ukiah, Willits, Redwood Valley, Potter Valley, and kind of that surrounding area. Hopland is served by Boonville. We could do that. So we included in there sort of the cost of the staffing. I needed to just note one thing with the staffing cost. There's the number's not completely accurate. We need to add 20,000 per team more. There was a little bit of a miss in the staffing cost, so it would be 20,000 per team more, so an overall 40,000 more in the staffing cost. We do have to have vehicles so that the teams can transport and work with individuals in the community. So that gives you, it's a one-time vehicle cost. And then obviously we have the additional yearly expenses, which is a variety of things from, what we call services and supplies. So paper, pens, you've got travel, you've got gas, you've got vehicle things, you're looking at operation, admin. So you're looking at a variety of things that also goes into their yearly cost to support their services that they do within the communities. So, Tom, did you have anything else to add?
No, so we currently have 3, and we're hoping that I'm hoping what we can do is recommend to the Board of Supervisors that through the Measure B services, remember that's 0.25% of the money that's collected, 0.25% tax, sales tax, is that we actually ask the Board of Supervisors to increase the number of MOPS teams out there with the Measure B money paying for 2 additional teams out there. The preventive or the reduction of the 911 calls is certainly apparent, as well as a number of people who are having psychotic episodes and having to be emergency transported to a hospital eventually to be taken out of the county.
I just wonder if you could help me visualize other things that this team does. I understand about what you were describing, but are there do they respond to crisis or to people who are having acute problems to try and keep them home, or do they visit them repeatedly on a weekly basis or something?
They visit them repeatedly, so they can be out there. If there's an individual that's high level that needs to be seen 4 times a week, they'll be at that individual's house 4 times a week. They do hold 5150 cards. They are certified, able to write 5150 holds. It's not the priority of the team is to be the crisis worker, because we have crisis workers through Redwood Community Services. The team does work closely with Redwood Community Services, especially if there is a crisis. There have been instances where the team has had to write a 5150 hold and transport the person to a local emergency room, and then they work with Redwood's team on making sure that the person gets hospitalized and stuff like that. So yes, they are able to do that. It's not the main part of their job, and because they're not 24/7, the teams are not 24/7, they couldn't be responding to every crisis. And then they also have appointments set up to, work with the clients they're working with, so they can't miss an appointment with the client all the time to, be just responding to crisis calls. But they do if they're available, and then they work really closely with Redwood.
Yeah, these are 5 days a week.
They are 4 days a week.
4 days a week.
Mm-hmm.
And then,
Just stay on that for a minute, and the hours, kind of what's the hours that they work?
They're working 8 to 6.
8 to 6.
Mm-hmm.
and then was that, it seems like I remember maybe the initial idea was that they were following up on people who were mental health patients that were recently discharged from jail. Is that the original intent?
The original intent was to have a support in the community to connect to local resources. They do if someone gets placed in the county jail, they will actually see the individual while they're in the county jail, and then work with them once they're released. There have been incidents, if we know that the individual is being released from the jail, that the team has picked them up and transported them back home and make sure they get connected. So they are working with people that are in custody and released from custody.
Yeah, just a follow-up question. Have you explored a need for longer hours as opposed or in addition to having more teams? Is there a need for the teams to be available on weekends or at night or something beyond an 8 to 6 schedule?
I don't know that I can't say we've really explored it. I'd have to look and it's something I'd have to look into to get the data on that.
So I believe once we could do our February training of the Mendocino Critical Incident Team training, the 24-hour training with first responders, and they will be interfacing more with the MOPS team. So when MSIT works with MOPS, we will certainly be able to do exactly what Jed's talking about of looking at our computer predictability of when these calls for service or these, we may be going out when these people aren't home, and we certainly want to go when they're home. So it's because this is so new, we haven't got to that point yet.
Good.
Mark?
So this is mainly preventative services for people that are already in the system and been classified, right? Or have their plan?
No. A lot of the clients that they touch are people that are not currently being served. So they're not in the system. It's not. Sometimes they're clients that have been in the system or are not connected currently, or a lot of times it's people who are either were in services at one time and then disengaged into services, or people that haven't been engaged into mental health services. So it's actually taking and connecting them to services.
So the request that's come from the stakeholders over on the coast is mainly what to do with people that are in crisis at that time. Does the MOPS people deal with crisis patients?
Not at the level that you might be interested in.
Right.
By
And
asking.
that still goes back to the emergency department and the sheriffs and the local law enforcement. So this won't help that
Well, that's
situation.
not exactly true, because in March of 2016, the Sheriff's Office did a 90-day study, March, April, May, looking at all 5150 calls that were non-violent, non-weapons, and non-threatening. And we found that only 30% of 5150 calls involved weapons, threatening, or violence. And so 70% of those crisis calls, we would love to get to a point where the MOPS team is responding at the same time law enforcement is responding. So we would have professional mental health advocates there that would be at step one of that, so.
Yeah, that's what this, reading what this isn't really what we need, right? Because you're not going to reduce your calls
Well,
because
actually,
they
we
don't
are.
work, the way I'm understanding it, it's an 8 to 5, 4-day a week, so they can't be responding to crisis situations for 5150.
I understand what you're saying, but what we've seen from this is the fact that at least once a week, the people who are potential 5150s are touching a professional and shaking hands or getting a hug or inviting into their house. What we're seeing is a reduction in the number of those 5150s who are repeat 5150s. And so we're taking away some of the frequent flyer 5150 calls and allowing them to be stabilized. And so,
but it's on the back end. Dispatch is not saying, hey,
that's
Bob's,
correct.
go deal with this.
That's
right?
correct. However, they're referred to by family members and from the mental health patients people may wonder, how does MOPS get involved in this? How do MOPS know to go to 123 Oak Street? And that comes from school references, it comes from family members, as well as medical facilities and the mental health staff that are given references of people who need that face-to-face contact.
The last thing, I don't want to monopolize this, but
Monopolize.
mop it. Have you seen a reduction since the MOPS program's been put in place?
Absolutely, and I can say this, the first 12 months that we did this, the MOPS people that were referred to MOPS, we saw, and I can't say this now, but we saw a 100% reduction in crisis 911 calls coming to the sheriff's office. Now, we've certainly had some that, were seen by MOPS and went into the crisis mode. But for the most part, I can easily say over 90% of the people that MOPS sees are no longer being crisis 911 5150-able.
And Mark, what I'd like to say is that yes, they're not going out in the moment we have a crisis, you need to come now, but they're getting the referrals early. So there's this relationship with the clinics and the community where the family members will say, hey, I think my family member is having some issues, can you come see them? They're not waiting until they need crisis, they're calling and asking MOPS to come in. So we're doing prevention services up front, and we get a lot of referrals, and they're out there and they're building great rapport, and so we're stopping people from getting to that crisis level by touching them right when they need it.
Jan?
I just also wanted to note again that in Kemper's report, one of the strong points that he made was to expand services to the outlying areas. And when the Behavioral Health Advisory Board studied the Kemper report, it looked like expanding the MOPS would be a really quick and easy way to do this because it's been so effective. On the condition that it include representation from the Sheriff's Office, which I guess wasn't true of a couple of teams. I don't know the details about that.
Right, there were some logistical problems, and Janine and I have had a chance to sit down and talk about this, and I think that if this committee can recommend to the Board of Supervisors that we add 2 more teams, I believe that many of those logistical problems can be taken away.
What was that financial logistical issue?
There were. The fact that there were sheriff service technicians that were paid close to $10 an hour less than the other person that was sitting in the car. And so you were having mental health people here and sheriff service technicians doing the exact same thing, and one of them was making $10 an hour more than the other person was. And so what I'm hoping to do is work with the personnel division of the county and have a classification made for that position in MOPS and hire people, and they wouldn't have such a disparity in their wages.
How does that relate to regular deputies?
The mental health person was making similar to what a deputy sheriff was, and the sheriff service technician wasn't.
Oh, there's a difference.
Yeah, much less. Any more?
Do you have your
Shannon.
hand first?
Oh,
Go ahead.
I'll follow you.
In general, I support expansion of the MOPS services, but I also appreciate that you say this analysis of the hours and effectiveness is coming. Because that's something that I would like to see also. I have this concern about it being kind of a Monday through Thursday, 8 to 6 operation, which may not be meeting the needs of a large number of clients. And so, if we move forward with the recommendation to add teams, then I'd also like to see it come back for additional review once that analysis has been done.
That's a very fair question, a very fair request, thank you.
Is that a motion? No, not necessarily. I'd like to hear from the rest of the board.
I'm actually kind of along the same lines. I was thinking, if this committee is going to make recommendations to the Board of Supervisors to spend taxpayer money, I think we need to, especially on something that is continuous and ongoing, that we need to have a way to close the loop to determine the efficacy of our recommendation. So if we recommend something, I think we need to have some kind of way to close the loop and measure, have some metrics, some measurables. And you brought up one. You said 100% reduction
For the first 12 months.
in the first 12 months. So, so what we're looking at, what I'm thinking is, well, we need to, validate that in some way. And I don't know if that's the best metric, but in some way validate it that this is a good system and it's really working, right? And long term, hey, because I actually do think that's a good thing, and it does align with Kemper's recommendation that prevention is the best medicine, right? So, but how do we close the loop on this and continue to make the recommendation to the board to keep spending the money? Because once it's spent, if we don't have some systemic way that we follow up on it, we're forgetting about it, and it's just being spent. And if it's not doing any good, it's still being spent. So I think it's incumbent upon us.
I agree, and actually some of that information is already there. Some of the data is there. I know that MOPS have presented to me monthly reports of how many people they're seeing at what location. And I agree with what you're saying. The efficiency of MOPS is, if we're asking for a 40% increase of this, are we going to see a 40% increase of number of clients seen? And I hope the answer is yes on that. So the data's there. We just need to get the data.
Yeah, and also how many sheriff responses in those areas are required for whatever 50% or something. And if we can have that ongoing, I would support this. If we're just gonna do this continuous, I'm nervous.
Dr. Barish, you have a question? Okay. Are there any more questions from the committee?
Why not?
Are there any public comments regarding this topic?
Is the report you referenced?
If you could please state your name and state your comment. Thank you.
Yeah, my name is Bill Keller. Is that report public information that you cited earlier?
Yes, it will be. I mean, no one's ever asked for it, but it will be.
Can you put it on the Measure B site, or
when we get it, yeah.
How can I get it?
Are you talking about the MOPS data report?
The report that the sheriff just
The sheriff
mentioned about 90%
reduction
reduction and 100%.
No, that's not on there. What I said, and I apologize for the miscommunication, is what MOPS produces is the number of clients they see. We don't mention names. The sheriff's office, we would have to have our employees see and measure which employees are seen as opposed to as compared to which employees are being seen by MOPS. Because there would be an apples and oranges comparison. If we have a number of 5150 calls and they're not being seen by MOPS, then that wouldn't be a fair analyzation. But I think that between the MOPS personnel and the sheriff's office, we can work on this one.
But I would say the MOPS data, if that's what you wanted to see, just kind of how many people we're serving, what areas, ethnicity makeup, and all of that, that is on the behavioral health recovery website. So it is on our website.
Oh, okay, thank you.
Yeah.
I just wanted to speak to Mr. Myrtle's question around how it doesn't meet. For the purpose that it has, MOPS is not meant to be a crisis intervention. They will often bring them to, if they're in crisis, to a crisis center or to an ER, which, by the way, until we have a CSU or something, is the only legal place that law enforcement can leave a client for a 5150 assessment. So it's not that MOPS wouldn't, it's not a legal spot. But what MOPS does do is provide tremendous amount. Not only do they deal with mental health clients, tend to engage and then disengage and come in and out of services depending upon how they're feeling. And the MOPS allows a little bit of leveling of the stabilizing of the waters for that population, which tends to be our most erratic. They also, in several cases that I can speak of, both on South Coast and Covelo, are part of our RAP team. So they're still getting intensive mental health services. They're still being served through intensive services by a provider. But MOPS is, in addition to that, being able to, no, you want to go see your therapist. No, the psychiatrist is good. Let's go see the psychiatrist. Let's take care of. So it is a very, very helpful. By definition, it's a prevention. So it's meant to be a prevention, early intervention, it's not a billable Medi-Cal service. It doesn't bring down federal match. But it's not standalone. It's very linked to the other services and supports. So.
Any more public comment? Okay, the next agenda item, E as N-word, I believe has been covered by Camille.
Excuse me, did I hear? Take action on?
Oh, I'm sorry, I apologize. Thank you, Jan, thank you.
I have another clarifying question, if I may. The proposal is to add 2 teams, one on the north coast and one inland, and I may just have missed this, but inland I wrote down Ukiah, Redwood Valley, Potter Valley. Does inland include Willits?
Yes.
Because, okay, there it is, Willits, got it, thank you.
All right.
I would like to also say that if possible, if we're considering this, maybe make it part of the budget that we're going to recommend to the board rather than just commit ourselves to spending the money.
Thank you very much, Lloyd.
Yeah. Okay.
So we're going to be doing the budget next month, and, all right.
We can decide.
All right.
If we're included in that.
Ross?
Can we ask that you guys bring forth maybe some metrics to measure the efficacy of the program so we can judge it a year from now and say, yeah, let's keep doing this?
Sure, we can.
I might have the numbers to go back 12 months ago from today, too.
So we're not gonna vote on doing it right now, so we're gonna vote.
No, we are.
Oh, we are?
We like,
Yikes. We don't have a system to measure it with. I'm hard pressed to support it.
Okay.
And I would move that we recommend to the Board of Supervisors that they create 2 more MOPS teams with some kind of metric to measure the efficacy of their work
with Measure B funds?
with Measure B funds.
Okay.
You wanna say it?
I like that. I just, what is that measurement and when are we gonna revisit that?
Tom said that he had metrics from 12 months ago, is that right? So that we could potentially say that this has worked, that you could give some sort of metric now.
Well, when this goes to the board, it's going to be a public hearing, and I believe mental health and between mental health and the sheriff's office, we'll be able to present the numbers of what you have. I just don't have them with me right now. So we have a motion on the table. Is there any discussion? Like Shannon?
I'd also like to add a review after we've had a chance to consider this additional analysis about the hours of use. Do you know roughly when that can be prepared?
I would recommend for at least after the February CIT training, when MOPS and CIT start working together and they can figure out how to adjust their hours and so forth. But
what do you think is a reasonable period of time to?
May.
Okay. Could say 6 months.
Okay, 6 months.
6
Jed?
months was in Kemper's report, a
Sorry.
6-month review on the strategic plan.
Oh.
Jed?
Yeah, my experience is that everything that MOPS does is the way to do early intervention for mental health services, because most of the people that go into crisis are known to, the community. We know who those people are likely to be. We know the problem is with their medication or whatever it is. So having that early intervention, I think, is a good expenditure of funds, and it's a good way to provide services. My only question kind of spoke to what I was saying earlier. I think increasing the services is a good thing. I'm not sure whether increasing the width of the service, in other words, reaching into other communities, or whether expanding the reach in communities to reach into later hours or weekends would be the most effective way. So when you say adding 2 new teams, I'm wondering whether that would include teams that might be working in the same area but would be working different hours, perhaps, if look like that would be a more effective way of reaching the population. That's all I'm asking, because I think it's useful, but I didn't get from you the data about whether more hours would be more helpful than reaching different communities. So either way, I think is a good way if we know kind of what Ross is saying, so we can measure where the effectiveness is and what's most helpful and how we can assess that over time.
We have a motion on the table. Are there any other comments? Mark?
Yep. I totally support this MOPS program. I think it's definitely the bridge between services and fills a void. I'd like to see more coverage of the days. Friday, Saturday, have it be a 6-day-a-week program rather than 4. But I second Janine's motion and think that it's a great program. And as far as touching the clients or the clients served, that would be a good metric, I think, to judge it. If it's not going up at least 40%, we have to start questioning it. So.
And let me just say, even if the board approves this, say in December, it's hiring people is about a 90-day process. So we're not looking to hire additional teams at least until March or April.
And Tom, just a clarification, this would be coming forward in the recommended budget,
Yes,
not as a separate item.
correct.
Okay.
Any other comments? We have a motion and a second. We have a motion by Jan, we have a second by Mark. Is it Shannon?
The motion and the second don't include a review in 6 months.
Would the maker of the motion like to change the motion to a review in 6 months?
Yeah, I mean, I'm sorry, yeah. That was another thing in Kemper's recommendations for action policy. And that's another recommendation of the measure of our advisory board is to review and amend the plan annually and review it every 6 months.
So you're changing your motion.
So we add that to the motion?
And add
That's what
a
we're asking.
review
Okay.
biannually, right?
Oh, that's fine.
Right.
Because maybe we'll want to add more, right? I mean, we can
Got
grow
that,
that
Dora?
really more.
Okay, any more committee members' questions? Are there any public comments? We have a motion and a second.
Just the
We
second.
have a motion and a second.
I would just like to have the motion reread, please.
Oh, man.
I'm sorry, because it kind of went.
I know. It's a test for
Yeah, I watched the video about 8 times when I'm doing the minutes. So the motion that I captured after all of that discussion is move to create 2 additional MOPS teams with Measure B funds and supply measurable metrics for the future of the program with a review of the program after 6 months.
Whoa, good job,
Good
girl.
job.
The only thing I would add would be recommend the creation of those, because we can't do that at the Board of Supervisors.
Okay.
In the recommended budget.
That's how I stated it.
I think so, yeah.
Okay.
So say that again, I'm sorry, recommend
Whatever.
Included in the recommended budget.
to be included in the recommend.
Actually, what I was saying was recommend the creation of 2 additional MOPS teams.
Right.
We can't create the teams. We're recommending to the Board of Supervisors.
Right.
If John was here, he'd help you out with that.
Recommend to.
Okay, we have a motion and a second. All in favor? Aye. Any opposed? We're opposed. Okay, that's okay. All right. Now, letter E as in Edward, Redwood Community Service Presentation, Facts and Figures. I believe that's all been done. Okay, so we combine D and E. Government is efficient. Number F, monthly committee update report. Board of Supervisors at the first meeting, who will present and what will be shared with discussion and possible actions. Chair Allman. I do this from putting together the bits and pieces, and I haven't been editorialized. I did 1 month and I got asked not to, and I haven't. However, let me ask this. Is there any committee member here who would like to do that presentation?
You do such a wonderful job.
Is that a yes on you, Jan?
I
It's
want
quite
to do it?
shelf.
No.
Oh, is there anybody who would like to do that?
I'm not raising my hand.
Okay.
I have a question on the bullet point when you get
Okay, I will continue doing it if this is, from the minutes of the, meeting. And it's all televised, everything else. If there's any more discussion, is there any public comment on this? Does anybody out there want to do it? Carol,
Don't want to do it. Carol
okay, please state your name for,
I'm getting ready to, Carol Hester, just a public person. Wonderful moms, I just think this is wonderful. Prevention always, but the public doesn't get to hear some of these wonderful decisions that are going forth. And again, I state, as I did the last meeting, that we voted for this, and that's been since November, and now we have a year gone by, and we're still, no, was it June? When did it pass? June. I don't remember.
past November and taxes were collected in April.
Yeah, but we're still in a committee. We're still not having, so MOPS is to me the only thing that's happening right now, and you're not being supported by Measure B funds right now at all, are you? Yeah, okay, so to me, it's a wonderful hello. We are getting down the road. We are recommending to the board that that this wonderful program be expanded with part of the Measure B funding. I think that's important for the public to know, because it's progress. Because all we see is no progress. So that's all I ask.
Okay.
Share your wonderful news.
Okay, we can put out a press release, I mean,
That's it, yeah.
Fortunately, we have people from the media here, and this is televised through our wonderful county IT people, who are appreciated. Any other comments on this? It doesn't take a motion, I'll continue doing it, but if anybody wants to, oh, Donna,
I just have, are we on the bullet point?
we're on the bullet point of F, yes.
Because I just have a question. It says the committee will include a written report and a vote from the committee. I read that as the committee votes on the written report that you will read. Is that correct?
Well, it's not, because I'm gonna be presenting this at the first Board of Supervisors meeting after this meeting. And this committee won't meet between now and the next Board of Supervisors meeting on December 4th.
So how do we vote for the written report?
Our clerk.
So what I've been doing is I've just been taking the minutes and giving the chair bullet points on anything that we've made decisions about, and that's what he's been presenting. But what you could do right now as a committee is just review what you've talked about today and say if we want that to be recorded, we vote on that, and then I'll put that together and send it to the board.
But it would slow down our input by a month. Am I getting that right?
No.
By 5 weeks,
What
yes.
you've discussed today, that's, whatever you decide would go to the board December 3rd. That's your next report.
Third?
So my clarification is just, it says there needs to be a vote from the committee.
Well, this was a recommendation from the Board of Supervisors. With all due respect to the Board of Supervisors,
He's looking around.
they can make a recommendation, but we're the committee. And they are not the committee's boss. So while they can make a recommendation, we certainly don't have to accept their recommendations, nor do they have to accept ours, although they have final financial authority. So I'm satisfied in giving a verbal report, unless the Board of Supervisors wants to send one of their clerks here to take minutes. There's no other logistical way that I can think. The county at this point, this is very important to say, the county does not have a full-time Measure B employee to do this. We're all doing it as other duties as assigned. And I do not have the staffing to do exactly what the Board of Supervisors is asking, but I would welcome the Board of Supervisors to give me that staffing, and I would do it. Jan?
So we could present the recommendation in writing since it was recorded.
Yes, the recommendation will be in writing to them.
Yeah, I mean, they told us the same thing. You know, you need to present this in writing after it was finished the night before. It's like,
No, we're gonna get an agendized item, For the MOPS, is that what you're talking about?
Right,
For our recommendations, yeah?
that can be in writing, I
Sure.
don't see a problem with that, but
No.
the report, fine, they can have a written report, and we can do it a month later after we've had our meeting, you know?
That doesn't work.
That is the option, isn't it?
Yeah, if they want a written report, it has to be approved, so
Yeah.
Be nice to
you
know.
can report orally, and then they'll get their written report on.
Would they get their minutes?
Exactly.
Okay.
Did that answer
Anna.
your question, Donna?
Yeah, it's just confusing the way it's written.
Oh, no, I think you
I
got
took
it.
it right
You
from
got
there.
I know,
You're not confused.
I know I'm not, but I just,
I took it right from the board.
No, if there's
No, it's
anybody
not.
on this committee who would like to prepare a written report for the board of supervisors, I would welcome you to do so.
But again, you couldn't vote on it until our
That's
next
right.
meeting. So.
Right?
You could vote by email.
I don't think you can. No, it's brown eye.
Shannon.
I'm not volunteering to write a written report, but this is kind of a related question. We can't vote on it, but maybe for an item for the next meeting. Dora does a fantastic job of doing summary minutes, and they were 17 pages long. And my question for the board is that do we actually need that? Because the videos to these are so accessible, can we go to action minutes? So that's not a question that, it's not something we can vote on today. But I'd like
I wanted to do that at the beginning of this, but you all voted to go to a summary.
So
I
maybe
have
we
no
could
problem doing that.
put that on the agenda for next time,
Okay.
and the rest of the committee can mull that over.
Okay? Let me say this. I asked Dora at the very beginning of the formation of Measure B to do this, and she reluctantly said yes, because this is a lot of work. This takes several days of her work month to prepare for this meeting and to do minutes. And I would welcome an opportunity for Dora to be able to do some of the other things which are on her table as well.
I'd like to request that that be an agenda item for the next meeting, please.
Got it.
It is on there, no worries. Thank you for bringing that up. Okay, so we've covered Measure F, and now committee member reports. Janine?
Just that I've been working on the MOPS presentation for today, and then obviously working with the subcommittee.
Jan?
The Behavioral Health Advisory Board has again studied the Kemper report in detail. And also, the NAMI Family to Family class concluded last night. So that's what I've been doing.
Thank you. Thank you very much. Doctor?
Occupied with the ad hoc committee and discussions about what we talked about today.
And I really thank the ad hoc committee, Mark, Janine, and Dr. Rich, for the presentation today. It was a good step forward. Thank you very much. Russ?
We blissfully have nothing to report.
Okay. Boyd?
Nothing to report.
Okay. Mark?
Fortunately, I have something to report. Had a Measure B coastal stakeholders meeting. Met with Dan Jurdy, District 4 Supervisor, Bob Edwards, Mendocino Coast District Hospital CEO, 2 nurses, Shelley Ware, Lynn Flinley from the hospital, Merle, can't pronounce the last name, and Mendocino Coast Clinics, Lucretia Renteria, Mendocino Coast Clinics, Bernie Norvell, Fort Bragg City Council person, and Emily Strachan, who's the, help me with the, Mendocino County Behavioral Health Board, District 4 representative. Meeting lasts about an hour. Items discussed were the state crisis stabilization needs for mental health patients. So as much of the same CRY employee that we're getting here in Ukiah, Willits, they're experiencing the same in Fort Bragg. It's not uncommon for 5 of the 8 emergency beds being held with 5150 patients. So they want an option to that. They don't know what that option is, but they want an option to that. There is an issue, it's a systematic issue that I think that can be dealt with existing services as far as getting 5150 patients transferred to RQMC and or to the hospital, which we're meeting next month, the first week of December, to discuss some of those things with RQMC. The second thing and the most glaring thing that they saw as an issue is the time lapse between when a person is in crisis to when they are in the system. And it can take up to 60, 90 days to get entered into the system. So that's not talking or taking anything away from RQMC's job. They do a great job initially getting in there, as they don't have the staff to get those people served adequately. So what I'm saying is when a person is in crisis, by the time they are completely entered into the system and getting the treatment that they need, they're out of crisis. And it's very easy for them to be dropped out of the system, because I'm not going through to that next appointment. I'm not going to do that. So if there is a way that can be improved, that was requested from them. Basically, that's my report. Again, we're meeting with these stakeholders and 2 representatives from RQMC the beginning of December. I'll respond with the report next month.
Okay, I know that Camille Schrader had her hand up during that, and we're going through the monthly reports right now. But I think it is a very, very important topic, and so after we're done with reports, Camille, if you'd like to give just a minute, when we're done with reports, please, we'll give you that opportunity, okay? Jed?
Nothing new from me.
Shannon?
I have been doing some work with the Mendocino County Continuum of Care. This is not specifically Measure B related, but homeless related. And as we all know, there's a lot of overlap. And so some significant sources of funding are coming to Mendocino County. The most pressing one is almost $5 billion coming to Mendocino County that will be applied for by the end of December. And there's significant support from the cities of Fort Bragg, the cities of Ukiah, and some of the supervisors as well to use these one-time sources of funding for permanent housing. And so because of that overlap between mental illness and homelessness, there's a lot of support for these projects that would include support services, wraparound services for homeless or at risk of homelessness clients. So that's really good news. There are a couple of shovel-ready projects, one in Fort Bragg, one in the Ukiah Valley, that could possibly take advantage of this funding, as well as some additional money coming down the pipeline. So I think the addition of this homeless-oriented money is going to have a significant positive impact on our mental health services as well.
Thank you. The only thing I have to report is we're continuing with the February 12th, 13th, 14th class. We're working hard on it, and I would welcome any of the committee members, if you want to join the first responders for a 3-day commitment, or to just drop in and see the class, you're welcome. More information will be presented in December. And please remember, at the beginning of this year, we changed our December meeting, so it's going to be December 18th. It's not going to be the normal 4th Wednesday.
So I'm going to go retroactive a little bit, but it is what I have done. As a Citizens Advisory Board, I think we need to address the needs of mental health, be fiscally responsible, and evidence-based. So I went to NAMI, since I represent NAMI, I represent family members and peers. And I'm only going to touch on what we talked about today, what their effective mental health crisis services look like, and there's a lot more, just going to touch on what we talked about today. Mobile crisis units which is a little bit different than MOPS. Crisis residential treatment, crisis stabilization units, extended observation units, and inpatient intensive treatment, whether it's a PUF or a general hospital. That's your building funds. Aftercare is taken care of with service dollars. And preventative, they love CIT. We are a sponsor of CIT training. So I just wanted to put that out there so you know where I stand representing, I hope representing, and if anyone's here who's a member of NAMI or is a family member or a peer, please let me know if I'm not representing you correctly. But that's what NAMI stands for. That's what I'm looking for. Thanks.
Thank you. Camille, would you like to address concern?
Actually, I.
Okay.
Thank you for the ad hoc meeting or the stakeholder meeting. Unfortunately, neither Camille or I were there. I did hear that comment was made about the 60 to 90 days. And so I really wanted to get up here and not, because it's on the record and we have media here, that is not correct. It is completely wrong. And I did hear that somebody used my name, so Dan said this. Camille said, make sure you're really assertive when you say that's not correct. And the fact is that if somebody's in a crisis experience, they get services that same day. They can get therapy, they can get rehab, they get case management. It starts immediately, and they get into a psychiatrist within a week. Just want to be really clear on the record.
So, yeah, I probably summarized this poorly, and obviously I did. They said you are great. You were there within 20 minutes when they're in the emergency room. They say that within 1 week they're served. The written report can take up to 30 days. Then after the 30 days, it can take up to another 30 to 60. So what I'm saying is we're not trying to badmouth you. If that was what was taken from this, that is not the case. They're saying there's a problem and a time lapse that can be improved, and we're going to talk about it next week.
We'll talk about it, and we'll plan to be there and to clarify, but the lag is not in services. There is an assessment process that Medi-Cal requires. It does not take 60 to 90 days, but I just want to be on the record here and not an argument or not to put anybody on the record.
I'm not trying to badmouth you either.
And I don't think you are. I just want to clarify for the record that is not the time that it takes for somebody to get in services. That's it. So thank you, but we'll be there and have that conversation.
All right, meeting adjourned. See you December 18th.
19th.
19th, my mistake.